Good afternoon, everyone. I'm Robin Grant, Director of Public Policy and Advocacy for the National Consumer Voice for Quality Long-Term Care. We go by Consumer Voice for short. And I want to welcome you to today's webinar entitled A Look at Public Policy in 2020. I also want to introduce Lori Smentenka, who's our Executive Director, and Jocelyn Bogdan, who's our new Program and Policy Specialist. Lori and Jocelyn will be coordinating the chat and question part of the webinar, for which I have to say, extremely grateful. So thank you. So as we start this new year, we wanted to share with you what our initial policy priorities are, give you some information about those issues, and then highlight how you can get involved and advocate. So first, a little bit of background. As I hope you know, Consumer Voice has a public policy agenda that guides our policy work. And the agenda includes a range of issues, but what we work on at any given time depends on a number of factors. And one of those factors is what we call a moment in time. And that means that sometimes attention is focused maybe unexpectedly on an issue. There could be a congressional hearing going on, or a major news investigation, or sudden interest by a member of Congress. And then it becomes really important to take advantage of that moment to advance a policy issue. And so this is what we refer to as proactive advocacy. At the same time, there are also issues that arise suddenly that may not be specifically identified on our policy agenda, but that could be harmful to residents. So that could be a piece of legislation or potential legislation. It could be action by a federal agency, a range of things. But in that case, we have to react immediately to advocate against those proposed changes. And so we refer to that as defensive advocacy. So our policy priorities right now are moment in time issues. I'm going to talk first about the issues we're working proactively on, and you can see on the slide that those are staffing, arbitration, background checks, written informed consent, and long-term care ombudsman program funding. Then I'll talk about the issues that we're facing where we need to react in opposition and do that defensive advocacy I mentioned. And right now, those issues are the proposed weakening of nurse aide training programs and reducing the frequency of the nursing home survey cycle. So after we've covered those points, we will open things up for your questions. Before we start, though, let me cover a few logistical details. I realized that in the promotion for the webinar, I neglected to indicate how long the webinar is, probably hoping that you wouldn't notice the time and I could talk and talk, but I am actually going to try to rein myself in. So the webinar will be 75 minutes and go until 3:15-ish. Other details, right now, all of your lines are muted to eliminate background noise so that everyone can hear. We'll answer questions at the end of my presentation, but if you have a question prior to that time, you can ask it whenever you want by typing it into your question box, which you should see on your screen. Also, I know people really want to know, so this is a major announcement, this webinar is being recorded, and we'll definitely send you both the webinar recording and the PowerPoint slides following the webinar. So not to worry, we know that most people really want copies of the slides, so they will definitely be coming your way. One last point, we're working on issue briefs on each of these issues, the policy issues that we're covering today. So those two will be coming your way soon. So with that, let's get started. And first up are those 5 priority issues that we're proactively working on. So as you can see from the slide, staffing is one of our top priorities. And I know that everyone on this webinar is aware of how critically important staffing is. I mean, adequate numbers of nursing staff, and by that I mean, certified nursing assistants, CNAs, licensed practical nurses, LPNs, and registered nurses, RNs. They are the foundation of quality care. I'm sure that each and every one of you can probably recount many stories about what you've observed or experienced or heard about happening when there aren't enough nursing staff to provide residents with the care they need. And in fact, that is the #1 complaint that all of us at Consumer Voice receive from residents and families, that there are simply not enough staff to provide residents with the care they need. So here are some things that you need to know about this issue and relating to minimum staffing standards. There is, not surprisingly, a strong relationship between staffing levels and quality care. I think we all pretty much intuitively know that there's that connection, but you need to know that over the past 25 years, there have been more than 100 research studies that have documented that relationship between nurse and nursing assistant staffing levels and outcomes of care. And that relationship is exactly what you would think it would be. When there are inadequate numbers of staff, the result is poor care, and then the reverse is also true. High total staffing levels, and especially licensed staff, have been associated with higher quality of care. One point I really want to clarify when we're talking about staffing right now, the nurse staffing levels that I'm talking about related to nurses and CNAs, what we're talking about here is direct hands-on care. Time that nursing staff spend actually providing care. It does not include time that's spent on administrative services or issues or other things like housekeeping tasks or supervising, charting, so on. So we're talking about actual direct hands-on care. So as I pointed out, there's a clear relationship between staffing levels and quality of care, but even though that correlation is very well established, the federal government does not require nursing homes to have a minimum number of direct care nurse and nursing assistant hours per resident day, nor is there any requirement for a specific ratio of nursing staff to residents. What we do have, the current federal regulations require sufficient staffing to meet the needs of residents, and that sufficient is not defined. From our perspective, it's extremely vague and ambiguous, and instead of a specific requirement, what we have instead is that each nursing home can decide for itself how many certified nursing assistants and nurses to assign, which leaves open the possibility that a facility can cut staffing levels dangerously low, often to drive up profits, but there is nothing that would stop them from doing that in terms of requirements. In addition, even though there's no federal requirements for a minimum standard, that doesn't mean that we don't know what it should be. There's actually a recommended minimum standard that has been determined based on evidence from a federal government study. So in 2001, the Department of Health and Human Services released a report that talked about specific minimum staffing thresholds below which quality of care would be compromised. And that report recommended a daily minimum standard of 4.1 hours of total nursing time. And again, that's direct care nursing time that I'm talking about. And the report also found that if staffing levels fall below this minimum, residents are put at risk. And one last thing to know is that nationally, based on data from the payroll-based journal system, which is the system which gathers staffing data from nursing homes. So based on that data, which was kindly and wonderfully analyzed by the Long-Term Care Community Coalition, the average number of hours of direct care nursing time per resident per day as of the second quarter of 2019, so it's behind a bit, obviously, but that number of hours was 3.4 hours nationally. So that's obviously well below the recommended standard. So given what a major concern staffing is, we are absolutely thrilled to tell you that there are two bills in Congress, one in the House and one in the Senate. Both are called the Quality Care for Nursing Home Residents Act. Both these bills address staffing, and both these bills have been introduced. So on the House side, we have HR 5216, and that was authored by Representative Jan Schakowsky. And in the Senate, we have S 2943, and that was authored by Senator Richard Blumenthal. So I'm happy and proud to say that Consumer Voice and other advocacy groups worked actually for many months with Representative Schakowsky's office to craft this bill. So I said both bills are identical. So they would each require nursing homes to provide that recommended government minimum standard of 4.1 hours of care per resident per day. The legislation specifically states that we're looking only at direct care time provided by nurses. In the bill, it refers to administrative services and the fact that they cannot be counted toward the 4.1 hours of care, and it defines administrative services. So on your slide, you can see a few key points about the Quality Care for Nursing Home Residents Act. Let's see, 4.1 hours are broken down by type of nursing staff. And this comes from that federal government study I mentioned. So of that 4.1, 0.75 hours must be provided by an RN, 0.54 hours from an LPN, and 2.81 hours of time from CNAs. The 4.1 hours are also broken down by shift. So we have 3 shifts, day, evening, and night shift. And I'm very pleased to say that one of the things this bill does by requiring each type of staff on each shift is that you end up with a registered nurse around the clock, which is something that we have been advocating for a while now. Finally, I want to note that the 4.1 hours are presented in both hours and as ratios. This has been a concern for quite some time, that talking in terms of hours per resident per day is not exactly easy for residents, families, people in the nursing home to easily understand. So it's also expressed in terms of a ratio. Both bills also talk about a certain level of nursing management personnel. So this is exciting as well. So in addition to a director of nursing, which is already mandated, there has to be a full-time RN assistant director of nursing and a full-time RN director of in-service training. So we're all very excited about all those points. So we will absolutely be working on an advocacy strategy for staffing, because this is such a critical issue. But in the meantime, we want to urge you to connect with your members of Congress and ask them to support the Quality Care for Nursing Home Residents Act bills, both, the one in the House and the Senate. Just an observation, in our work, we have been struck by how often members of Congress hear from the nursing home industry, and how rarely they hear from residents, families, ombudsmen, and other advocates about the problems that residents face. This means that it is so important that you share with your members of Congress what you've experienced, what you've observed, so that they understand what is actually happening in nursing homes in their area, and that they realize the impact that lack of enough staff has and why staffing matters so much. Okay, well, let's move on to another priority, and next up is pre-dispute arbitration. Ending pre-dispute arbitration agreements in nursing homes, as well as other long-term care settings such as assisted living, has really been a priority of consumer voice for years now. Just a quick explanation of pre-dispute arbitration agreements for those of you who are new to the issue. Arbitration agreements basically take away an individual's right to hold a nursing home or other long-term care provider accountable in court for any and all potential negligence or wrongdoing. So instead of settling a dispute or a claim in court, arbitration is a legal process in which a dispute is settled by one or more arbitrators who decide the outcome. So that's what arbitration is in general. Pre-dispute arbitration is exactly what it sounds like. It means that the consumer is signing away their right to go to court before any dispute arises, and without even knowing the nature of the dispute. And dispute may come across as something that seems fairly, not terribly serious, but a dispute can be severe neglect, serious injuries, or even death. And that's the kind of thing then that would be arbitrated instead of going to court. So from our perspective, and that of many others, I'll add, pre-dispute arbitration agreements essentially deprive residents of their constitutional right to seek justice before an impartial judge or jury, and that's even for the most egregious harm. It's really hard to find any benefit to residents to signing pre-dispute arbitration clauses, but there are certainly many disadvantages. So just a few examples. Pre-dispute arbitration agreements prevent informed decision-making. That's because you're forced to make a decision in a vacuum without any information at all about the dispute. These agreements take advantage of consumers at their most vulnerable. We know that nursing facility admission is a really stressful, difficult time for residents and their families, and they're under often extreme pressure to find nursing home placement quickly. It is not a time when they are going to be able to really process that they are giving away a very fundamental right. Individuals are handed a stack of paper. They're generally unaware of what they're signing, and certainly not in a position to be, fully appreciative of the fact that they're giving up a constitutional right. So it's a bad time for folks when they're admitted to nursing home or other long-term care services. These agreements are just fundamentally unfair to consumers. They allow, many of these arbitration agreements let the facility select who the arbitrator is. They get to select the rules, where it will be held, and there's often a strong incentive for the arbitrators to find in favor of the provider because that will probably assure them of repeat business. And finally, arbitration can be expensive. It's often touted as a lower cost, but it can be equally or even more costly than going to court. So for a very brief moment in time, when the revised federal nursing home regs came out in October of 2016, there was a requirement that banned these agreements in nursing homes. And it looks like the end of the use of pre-dispute arbitration agreements in nursing homes. That was a wonderful moment that ended sadly very, very quickly. The ban was reversed in a final arbitration rule that was issued by the Centers for Medicare and Medicaid Services, CMS, in July of 2019, and it basically permits nursing homes to continue to use pre-dispute arbitration agreement. But fortunately, this is a significant moment in time because there are a number of bills related to arbitration in Congress right now. So we are very, oh goodness, let's see, I jumped all the way to the end. Okay, let's see. There we go, okay. So there are 3 bills right now that are in play. The first is the Forced Arbitration and Justice Repeal, which is referred to as FAIR Act. And this is a very general ban of arbitration. It would apply very broadly to companies, just in general, that require workers and consumers to use arbitration. And it actually refers to forced arbitration, and that's the idea that basically people are forced to sign and to agree to arbitration if they want to receive a service. So for example, if somebody wanted assisted living services, they would have to sign. And again, this would also be before a dispute, so it's pre-dispute. But this bill would apply broadly to a range of consumer claims, and it would apply to nursing homes. So in addition to this broader FAIR Act, there is a bill that's called the Fairness in Nursing Home Arbitration Bill. This would ban nursing homes and Medicaid-funded providers of home and community-based services, and that would include assisted living facilities that receive Medicaid funding. It would ban those providers from using pre-dispute arbitration agreements. And then finally, there is the bill that I talked about previously, Representative Schakowsky's and Senator Blumenthal's Quality Care for Nursing Home Residents Act, and that includes a provision that would bar nursing homes from utilizing pre-dispute arbitration agreements. So any one of these bills, if it were to pass, would end pre-dispute arbitration agreements in nursing homes. So there are a lot of possibilities here. So the advocacy action here for pre-dispute arbitration is just very simple. It's contacting your members of Congress and asking them to support all of these House bills, as well as the Senate version of the FAIR Act and the Quality Care for Nursing Home Residents Act. So we hope that's something you'll consider doing. Third policy priority is mandatory comprehensive national background checks. You know, ending nursing home abuse has always been one of Consumer Voice's priorities, but it is currently just red hot. The issue of abuse, I should say, has been in the spotlight a lot recently. In fact, starting with a Senate Finance hearing in March of 2019. It was the subject of a second Senate Finance hearing in July of 2019. There have been numerous reports by federal agencies, and it's been the subject of many news articles. So this is a major, major moment in time issue. So certainly ending abuse is definitely a complicated issue, but we believe that one very practical, common sense step that can be taken is to prevent abuse in the first place by screening out individuals with records that pose a danger to residents, person, or property. So there are a number of things that you should know related to background checks. Two very important facts that come from Office of Inspector General studies. First, there are studies that show that employees with criminal convictions, actually the studies show that there are employees out there, they've been found with criminal convictions who then go on to abuse again, who could have been screened out through background checks. And second, we also know that nursing homes are hiring people with criminal convictions. For instance, the OIG found that, and this is quite a shocking statistic, but 92% of the nursing facilities they examined employed at least one individual with at least one criminal conviction. So this is in part because although many nursing homes indicate that they perform background checks before hiring, the current screening process is clearly not effective. And a major problem with existing screening is that facilities frequently look just at state nurse aid registries and state criminal history. But state checks alone are just not sufficient. If you have an applicant who's been convicted of a crime in another state, it's not going to show up necessarily on the state background check. And that then allows criminals to move from state to state and secure jobs in long-term care settings where, sadly, they can continue to abuse. So what is needed is a comprehensive national background check. And comprehensive in this instance means that it includes searching registries, such as nurse aid registries and sex offender registries, and criminal history for an individual. National means that it includes national level criminal history check of FBI records, in addition to a state criminal history check. So the national means that we're going into FBI records. So this is an approach that is taken by a program that's called the National Background Check Program. It was created under the Affordable Care Act. It is a voluntary program, and it was designed to give states funding so they can implement this kind of comprehensive national background check. And I should say across long-term care settings. It applies not just to nursing homes, but to other long-term care providers as well. What you should know about this program is that it has actually been wildly successful. 29 states have already created such a system or are in the process of doing so. It's screened over 2.7 million individuals. And in just 8 states alone, it has disqualified nearly 80,000 individuals with a history of patient abuse or a violent criminal background. But currently, nursing homes don't have to conduct comprehensive national background checks. Neither federal law nor regulation specifically requires nursing home facilities to check state or federal FBI criminal history records for prospective employees. So one of the things we are doing is advocating for nursing homes to be required to do this type of comprehensive national background check for each person who has direct access to residents in nursing homes. And it just straightforward, bottom line is that we think that this is a sensible step to protect residents, many of whom may not be able to defend themselves, may not be able to remove themselves from danger, or even report or recognize abuse. So one last thing that you definitely need to know is that the system I've just described is very different from an entity that's called the National Practitioner Data Bank. And the nursing home industry is pushing for nursing homes to have free access to the practitioner data bank. But the key is in lieu of a national background check program. So certainly there's absolutely nothing wrong with nursing homes being able to access the data bank. We certainly would support that, but it is not a substitute for a comprehensive national background check. And let me tell you why. Two key reasons. First of all, it doesn't apply to all nursing home employees with direct access to residents. So for example, housekeeping staff, maintenance staff, kitchen staff, bookkeeping staff, those folks like that, they would not be subject to a criminal background check. And secondly, it doesn't provide information about criminal convictions that are not related to healthcare services or items. The practitioner database focuses solely on healthcare-related criminal convictions. So this means that it would not protect residents the way a comprehensive national background check would. It is not a substitute. So the ask here, the advocacy message to Congress is to build on what we already have, expand the national background check program by making funding available to those remaining states that haven't yet implemented the program. There should then be a phase-in period for those states to come up to speed. And then we're advocating that all Medicare and or Medicaid certified nursing facilities be required to conduct this comprehensive national background checks on anyone who has direct access to residents. And we're giving some time for facilities to put all this into effect. So it would go into effect by 2024. And we envision that this would be a federal regulation. Okay, next priority that we're working on is to require written informed consent for antipsychotic medications in nursing homes. So here's what you need to know. Unfortunately, inappropriate use of antipsychotic medications has long been and unfortunately continues to be a nationwide problem. Although there certainly has been some progress made, national data shows that antipsychotics are still being given to about 20% of nursing home residents nationwide. That is a really high percentage. So why is there such a concern about antipsychotics? Many of you, I'm sure, are well aware of this, but it's well established that antipsychotics can be very dangerous for older adults, particularly those with dementia. We know that when they're prescribed for older adults with dementia, they can have very serious medical complications. So that could be oversedation, confusion, increased respiratory infections, falls, and strokes. And in fact, these drugs can be so dangerous that the Food and Drug Administration has issued what's called a black box warning for antipsychotics, and the warning states that individuals with dementia are at increased risk of death from their use. So these drugs are definitely, can definitely be quite dangerous. So in addition to the health, the impact they can have on someone's health, they can also destroy, sadly, the quality of life and dignity of nursing home residents. They can be so powerful that they sedate residents to the point where they become unresponsive, and sadly, they can be slumped in wheelchairs, unable to get up from bed. They may no longer be able to participate in activities that they enjoy or even talk with their loved ones. There's also concern because far too often antipsychotics are sort of given as a means of controlling behavior when residents show signs of distress, such as agitation, instead of providing person-centered, individualized care and adequate staffing. Despite these dangers, the vast majority of residents and families are unaware of the serious medical, psychosocial side effects, and even the risk of death from antipsychotic medications. You know, the potentially lethal side effects are frequently not shared with residents and their representatives. According to one family member in a report, she said, "I had no idea, not at all, that the drugs were dangerous." And in fact, antipsychotics are frequently given without legal consent for treatment and without even telling the resident or representative, you know, let alone asking for consent. They're not even told. And here's what one resident stated in the report. "They crush it, so you don't know what you're getting fed. You know, they put it in the applesauce." So residents aren't notified, families aren't notified. We've heard from families who've reported visiting a loved one only to find him or her completely sedated and unresponsive. They had no idea what had happened until they were told by facility staff that the resident had been given an antipsychotic medication. So when these drugs are administered without informed consent, people are not being given an opportunity to decide for themselves what is best and whether they want to accept that risk. So right now, there's no federal law, there is no regulation that mandates that written informed consent be obtained prior to antipsychotic use. And so that's why Consumer Voice has made advocating for legislation to require written informed consent a priority. And such a requirement, I think, would really help ensure that residents, representatives get this critical information about antipsychotics, that they get information about the risks before they are administered. And we also think that written informed consent would also assist, we hope, in reducing the continued misuse of these drugs. There's been an effort on the part of CMS, the National Partnership to Improve Dementia Care, since 2011. And it's been working to reduce the use of inappropriate, or the inappropriate use, I should say, of antipsychotic medications. You know, progress has certainly been made, but as I noted, 20% of residents are still being given these drugs. So it certainly seems that the regulatory system has not proved adequate to limiting the use of antipsychotics. And we believe that written informed consent provides just another level of protection for residents. So how can you make a difference? You can contact your members of Congress and ask them to support the Quality Care for Nursing Home Residents Act. That bill, I have to say, is amazing. It has so many different provisions in it. So in addition to the minimum staffing standards that I talked about earlier, it includes a provision that would require the Secretary of the Department of Health and Human Services to work with a stakeholder group, which would include advocates, to develop a standardized protocol that nursing homes would use to get written informed consent. So that's something that is out there and that we can currently support and work to get passed. But you can also just in general ask your senators and your congressperson to support any legislation that would require written informed consent for use of antipsychotic medications. So the last proactive priority that I want to cover is funding the Long-Term Care Ombudsman Program. I know that many, if not most of you on this webinar are familiar with the Ombudsman Program. Many of you are actually ombudsmen. But for those of you who aren't, and for those of you who may be new to this field, Ombudsmen are advocates for residents of long-term care facilities. And under the Federal Older Americans Act, every state is required to have a state long-term care ombudsman program. Well, there's obviously a lot that you need to know about long-term care ombudsmen, but just a few highlights right now in terms of our policy efforts. First, long-term care ombudsmen advocate for residents in a number of ways. And one of the primary ways that they do that is by investigating and working to resolve complaints that are made by or for residents. And I think that the number of complaints that are handled by ombudsmen is enormous. In 2018, ombudsman staff, along with volunteers, investigated 194,516 total complaints that were made by 123,066 individuals. And the vast majority of the time, in fact, ombudsmen resolved or partially resolved those complaints to the satisfaction of the resident. And in fact, 74% of complaints were resolved or partially resolved. So that is, I think, a very high success rate and shows how very much ombudsmen are helping residents in improving the quality of their care and quality of life. So in addition to doing this individual advocacy with residents, ombudsmen also advocate for improvements in the long-term care system in general. They educate and provide information on a range of topics like residents' rights, good care practices. They promote the development of resident and family councils and a lot more. Because the program protects residents' rights and helps ensure that residents get quality care, the program is really, I think, critically vital to long-term care facility residents. And it's important, I think, to note that it's the only program that's federally mandated to advocate on behalf of residents of long-term care facilities. The only program. And residents and families need this assistance because the issues that arise for residents living in a long-term care facility can be very complicated. And many residents don't have family or friends to visit and to help. And that means that the ombudsman may be the only outside contact that a resident sees and trusts to help them with concern. So without access to the ombudsman, residents don't have an advocate who provides this education, this empowerment, and complaint resolution to address a range of issues that a resident may encounter. And we know from years of ombudsman advocacy that the program can really best help residents when ombudsmen visit facilities and connect with residents on a regular basis. Residents get to know the ombudsman, they come to trust the ombudsman, and they will then confide in the ombudsman and talk about concerns. Unfortunately, this access to the ombudsman is limited for many residents. In 2018, ombudsmen were unable to visit almost 30% of nursing homes on a quarterly basis, while approximately 70% of board and care, assisted living, and residential care facilities, whatever you call that entity in your state, did not receive a quarterly visit. So when ombudsmen are not able to do those quarterly visits, that means that that's going to limit resident access to ombudsman services. And it all, or much of it, goes back to a lack of adequate financial resources, and that is limiting the number of residents that ombudsmen can assist, even though many programs work very well and very cost effectively with volunteers. So to improve resident access to Ombudsman and their services, the program absolutely has to receive more funding. Over the years, the number of long-term care facilities has increased, the number of beds have grown, but the funding has not increased comparably. So for example, since 2013, the federal funding for the Ombudsman program has not even increased. It appears by, it hasn't even increased by $1 million. So that is woefully inadequate. So as advocates, all of you can take some important action here. You can ask your members of Congress basically to increase the funding for the Ombudsman program in a number of ways. Increase Title VII funding to $35 million, so this adds to the core funding of the program, and which has been very limited over the years and was really hit by sequestration several years ago. Ask your members of Congress to authorize $20 million for funding Ombudsman services to assisted living residents. So the mandate of the Ombudsman is to serve nursing home residents and also assisted living residents. And the mandate for assisted living was added in 1981, but there has never been an authorization of funding for Ombudsman to serve assisted living residents. So as a result, the residents in assisted living facilities don't have the regular and timely access to the Ombudsman program that we know is so important for them to be able to confide about problems and have those problems addressed. Also, advocate for $5 million from the Elder Justice Act authorized funding to go into an appropriations bill for FY 2021. Because the funding is associated with the Elder Justice Act, it would support work to protect and prevent and respond to abuse of older Americans who are in long-term care facilities. So it's absolutely critical that we increase this funding for the program. I do want to also add that I hope your advocacy message will include that there needs to be increased support for the National Long-Term Care Ombudsman Center. NORC, I will brag about them. NORC does amazing work, and it's there, has been, and continues to support Ombudsman programs nationwide, both state programs and local programs. It provides technical assistance, training. It really equips Ombudsmen to do their jobs, but it can't do it without increased funding in order to continue to do its wonderful work. So as I said at the beginning of the webinar, the 5 issues that I've just discussed are all issues that are part of our public policy agenda and that we have prioritized as we go into 2020. But sadly, there have been some legislative issues that have come up that if this legislation is passed, could really negatively impact the well-being of residents, their safety, and their quality care. So as you can imagine, we're very concerned about those issues, and that's where we are doing our defensive advocacy work to oppose those 2 issues. So the first issue is related to nurse aide training. I think we would all acknowledge that CNAs are the backbone of nursing home care. I mean, they provide the majority of hands-on care to residents. But in order for residents to get good care from CNAs, those CNAs need to be well-trained. And to be well-trained, they need to have competent nurses who serve as the trainers. So, and that's why right now, current nursing home law requires that nursing homes that provide nurse aide training on site, so in their facility, by their own nursing staff, to do that, they have to meet certain standards. And if a facility fails to meet those standards, they are then prohibited from offering the training program themselves for a period of 2 years. So that has been the law for many, many years, but now there are proposals that have been initiated by the nursing home industry that would roll back the existing standards. And we believe that the proposal to roll these standards back would likely result in less well-trained staff and in turn, possible resident harm and poor health outcomes. So here are some things that you need to know. The current standards under the current law contain important protections for residents. So the circumstances under which a facility conducted training program, and by that I mean a training program that facility staff themselves conduct, the circumstances under which that can be prohibited or banned, and the length of the ban are all designed to protect resident health, safety, and well-being. So one reason the training can be banned is if the facility has a waiver because it doesn't have the required number of nurses. A waiver means the nursing home already has a shortage of nurses. So taking nurses off the floor to provide training would lead to even fewer nurses to care for residents. So if there's a waiver in place for nurse staffing, then a facility cannot conduct its own nurse aide training program. So other reasons for banning a facility-conducted nurse aide training program includes if there are serious deficiencies, if the facility has been issued a fine that is at least $10,000 and $697 or $10,697. Sorry about that. Or if one or more of what are considered some of the most severe penalties have been imposed, and an example of that kind of penalty would be banning any new resident on Medicare and or Medicaid from being admitted to the facility. So the idea here is that the quality of the training could be seriously jeopardized if the care and conditions in a facility have resulted in this level of violations and this level of penalties. I said that the ban is 2 years. The reason that's critical is to ensure that the facility has corrected the violations for longer than just a few months. Otherwise, what could happen is the facility may fix the deficiency related to the CMP, for instance, patch it up, put a Band-Aid on it enough to pass kind of a reinspection, a revisit, but then because there wasn't a lasting fix done, it is very likely that the same problem would recur shortly after. We kind of call that yo-yo compliance, where a facility comes back into compliance for a short period of time and then the same problem occurs again. So if you have a 2-year period of time, you can be better assured that the facility has made some lasting and substantial improvements related to that problem. But the proposed changes would, we believe, dangerously weaken the current standards. Almost all of the current circumstances under which the facility can be banned from offering its own nurse training would be eliminated. So for instance, a facility could offer its own training program even if it didn't have the federally required number of nurses. So that part would disappear. It would also be permitted to conduct its own training if it received a fine of at least $10,697 for a violation. And bear with me, this gets a little geeky and technical here, but they could do their training if the fine does not fall into what is called the substandard quality of care category. Now, that is a term that is defined by regulation, and it means that substandard quality of care means there's certain regulatory sections like quality care, as well as some specific requirements in certain sections that are regulatorily defined as substandard quality of care. So under the proposed changes, a deficiency would have to fall into that category in order to have a ban kick in. The problem with that, and the reason we're very concerned, is that there are many really important care-related violations that don't fall into this category of substandard quality of care. So for instance, if the facility failed to establish and implement an infection prevention control program, something that is incredibly important, that would not trigger a ban. And mind you, CMS itself states that about 388,000 residents a year die from infections, but infections would not affect the ban. Also, if a facility didn't have nursing staff with appropriate competencies and skills to care for residents, that also doesn't fall under substandard quality of care. The ban would only be applied under these proposals if the facility has gotten a fine of at least that magic number, $10,697, for any violation that falls into substandard quality of care, and it must not have corrected the violation. So those two things are what would trigger a ban. And since the vast majority of nursing homes correct violations enough to pass a re-inspection, it just seems that this criteria would almost never apply. So in general, this proposal would make it easier for facilities with poor care to train new aides. And that in turn is likely to result in the continuation of poor care practices and as a result, continued harm to residents. So the one last point here is that the proposed changes would also eliminate the 2-year ban. And instead, the facility could provide its own training program as soon as the facility had corrected the violation. So this would obviously be a much shorter period of time than 2 years. And we're concerned that that would not be sufficient to determine if the facility has truly resolved the problem or instead just put a Band-Aid on it. And finally, the proposed changes in the law we think are just unnecessary. First of all, most of the concerns raised by proponents of this proposal are already addressed in the existing law. So proponents claim that the current law is unfair because it penalizes facilities for violations that have nothing to do with resident care, and because rural facilities under a ban would have difficulty training aides. Yet, all facilities in these situations can apply for a waiver. The law allows for facilities to receive a waiver from the ban if the CMP was not related to care, or if there are no other training programs nearby, which would be the case with rural facilities. Proponents also claim that the ability to train nurse aides is crucial to creating a pipeline of qualified staff, and that this will address the critical shortage of nursing staff. this is certainly an issue, but it's really important to note that the current statute does not end a facility's ability to train aides. They can continue to train aides. All they have to do is bring in an outside instructor. So on this slide, you can see that there are now 3 bills that would weaken the nurse aide training program standards. And actually, I wouldn't be surprised if this popped up in other bills as well. So the advocacy action here is very straightforward. Ask your members of Congress to oppose these 3 bills and any other legislation that would weaken existing law that governs these facility-conducted nurse aide training programs. All right, last priority issue is to oppose reducing the frequency of the nursing home survey cycle. As you probably know, federal law requires nursing homes that receive Medicare and or Medicaid funded to be surveyed every 9 to 15 months. So CMS has indicated that inspecting 15,000 or so nursing homes each year is too costly. And they actually are asking Congress to reduce the overall frequency of nursing home inspections for so-called top performing facilities. And they want that frequency to be reduced to roughly every 3 years. So that is a request that CMS has made. It's made it very publicly. And there are also a number of members of Congress who have also expressed interest in reducing the frequency of the survey cycle. For Consumer Voice and other advocacy groups, these annual surveys are absolutely essential to protecting residents, and the idea of reducing the frequency of those surveys in so-called, good or better facilities is really likely to undermine the safety and welfare of residents. So here's what you need to know. Well, and you probably already do know that nursing home quality can decline incredibly rapidly. A good facility can quickly turn into a bad facility for a number of reasons. It could happen if there's a change in ownership, a change in on-site management, like the administrator or the director of nursing. It depends on staffing, funding, many, many factors. And all of these things can change dramatically over the course of weeks or months. So major concern if you were to go for 3 years without surveying a facility. Abuse, we know, also occurs in the so-called good or top performing facilities. A recent study that was done by the GAO found that almost 7% of 5-star nursing homes had an abuse deficiency in a 1-year period, and 3.6% had an abuse deficiency in 2 or more years. So good facilities are not abuse-free. We also know that annual surveys are really essential for identifying abuse. That GAO report that I just mentioned found that 1/3 of all abuse deficiencies are identified through a standard survey. So that's the annual survey that's conducted. So if we were to decrease the survey frequency, that would likely mean that a significant amount of abuse against residents would not be identified or sanctioned. And lastly, change in the law is unnecessary. CMS already has the authority to vary survey frequency to focus more on problem facilities and less on high-performing facilities. The law, permits surveys to be conducted every 9 to 15 months. So survey agencies can send fewer surveys into the high-performing facilities every 15 months, and that would free up resources to increase oversight of facilities with chronically poor care. So no need to change the law. So what can you do? You can ask your members of Congress to reject any proposal to reduce the frequency of nursing home surveys. Thankfully, we don't have any legislation if I say this, I'm afraid I'm going to jinx things, but to date, there isn't legislation that would call for the reduction of the frequency of surveys. And we hope that that continues to be the case, but talk with your members of Congress and tell them to say no to any proposal that should one appear. And also ask them to support increased funding for CMS oversight and enforcement. That is the fundamental issue here. Funding for CMS survey and enforcement activities, and that includes funding for state survey agencies, has been inadequate for quite some time now. And we know from many of you that your state survey agencies are really stretched so thin that many of them have problems completing the required duties within mandated timeframes. And so there are, we've heard reports from states where surveys are not being conducted every 9 to 15 months because they can't get to them. They have so few staff and they're so stretched. So that is partly why I think saving money by not inspecting these so-called good nursing homes is appealing to CMS and to some lawmakers. So we need to ask that Congress appropriate more money to bolster the survey process itself, rather than looking to harmful alternatives to bring costs down. So with that, I will stop talking. You've heard a lot from me, and we will open things up for questions. And just as a reminder, to ask a question, just type it into the chat box. And so I will turn things over to Lori and Jocelyn.
Thanks, Robin, for your excellent presentation. A lot of issues, obviously, to be tracking right now. There have been some questions come in, and we have maybe 5 to 10 minutes left, and so we'll go through as many of them as we can. And if we can't get to all of your questions, we'll do our best to include, as we send out the issue briefs, hopefully that will answer some of the questions that you have. And certainly you can always reach out to us independently and we can do our best to answer them. So one of the questions, Robin, came in about the staffing standards. And can you share what you know about how the standards were developed in terms of the hours per resident per day?
That's actually an excellent question. My understanding is that there were time studies that were done. I think key care activities were identified, and then the amount of time it took nursing staff to conduct those activities was observed and then recorded and then calculated. So that was what the 4.1 is based on. I will add that we know that caring for residents is not just a sum of the amount of time it takes to do, X number of care activities. So if anything, that number should be higher, but that is what the government study used, I think, to come up with the 4.1.
Mm-hmm. Thanks. And on our on the Consumer Voice website, we have a page on staffing, and you can also see some of the reports and research that have been done there that led to the standards that have been proposed too. And you can just type in staffing in the search bar on our website, and that'll come up. Another question related to arbitration. there was a question related to whether families and residents could even today cross out the section on arbitration but agree to the other provisions in the admission agreement. And do you want me to take that one?
Sure, if you'd like to.
Okay, so the answer is yes. So if you are going into a nursing facility and when you're presented with the admissions agreement, if it has an arbitration clause, the resident or their legal representative can cross out the arbitration provision there. I would suggest that you put initials by it and date it to indicate, that you crossed it out at that time. They cannot require, as Robin had said, that you sign it as a condition of admission or of continued care. If you do happen to sign an arbitration agreement, you have 30 days to rescind it. So that is something that is a current requirement. Let's see, a couple questions came in about where folks can find the list of those states that are participating in the that require comprehensive background checks. So the list of, I think, 29 states that are currently participating in the program.
That I'm thinking, I think it's in, it would be in one of the OIG reports. So I think I'd have to dig a little bit to find exactly where it is, but it is something that I've seen in OIG reports. Okay. And particularly the most recent one, I think, had the 29 states. Mm-hmm. Laura, is there a way that I can, I tell you what, we will include that in the issue brief. How's that?
That would be great.
Good question.
Okay. Mm-hmm. A comment from someone agreeing with you that not having an infection control program should fall under substandard quality of care when you were talking about the substandard quality of care issues related to the ban on nurse aide training. So that is certainly an important provision. Let's see, another check. Is there, related to the background checks, if they are required in states, the question is who would be in charge of conducting the background check? And it would be the facility that would be responsible for that, isn't that? Yes,
yes. Yeah, it would put in the request, and then I think it would go to, so then at that point, probably sometimes it's the state police, whoever would do the state criminal history part, and then the request would go to the FBI.
Mm-hmm. Okay. There was a question, if you could maybe go back in your slides to the one on the state training bill, the bill numbers. Someone asked about
absolutely.
Those. Get those bill numbers again.
Training, okay. The nurse aide training program?
Yes. Mm-hmm. So for the person that asked that question, you can see them right there. There was a question about.
I have to make one little. I find the names of these bills to be very interesting. So, anyway.
Yeah, the names of bills are always very interesting, I think, and don't always reflect the content of them.
Yeah, we would name them something different, but yeah.
There's a question about the use of antipsychotic medications and who decides appropriate versus inappropriate use of those drugs. Do you want to just touch on that real quickly?
Well, I think it depends on, well, there are many factors that go into whether something is appropriate or inappropriate. It would be, we would consider that it would be inappropriate if, say, a resident was exhibiting, showing signs of distress and non-pharmacological interventions hadn't been tried, because it's quite possible that would have addressed the individual's expressions of distress. So that's one factor that would make it inappropriate. using, well, also if it's not properly monitored, that would be inappropriate. If it's, trying to think of some other reasons here. You want to jump in, Lori? I'm having a blank out here.
Sure. Well, certainly appropriateness of the use of the drugs is also relative to the diagnosis of the person. So an individual who has mental health needs or a diagnosis such as schizophrenia, for example, that would benefit from the use of that drug is, and for which the drug was made, certainly that's one where we see appropriate use. But when it's being used off-label for someone that does not have that diagnosis and it's being treated off-label to really either for the convenience of staff or to sedate the person or to alter their behavior, that's where we question the use of those drugs then.
Thank you. Great.
There's another question related to, and this relates to the changing the frequency of the surveys, because we talked about what they're saying is that the best performing or higher performing facilities would potentially not be subjected to an annual survey should those provisions pass. And so the question was, what makes them a best performing or higher performing facility?
That is absolutely the question. And certainly a question that we've been asking. That has not been defined in any proposal that, or any discussion that we've been part of or anything that we're aware of. And so all of that would be to be determined. So we really don't know. And that is, in fact, one reason why we're so concerned.
Right. Absolutely. So thank you, Robin. I think we're at the end of our time for today. I'm sorry that we did not get to all of the questions, but thanks so much for all of you participating. And Robin, thank you for your excellent presentation. As Robin mentioned at the beginning of the webinar, we will be sending out the slides as well as a recording of today's program. And we will also be sending out issue briefs related to all of the issues that Robin talked about. So stay tuned for more, and thank you for participating today. And Robin, thank you for your presentation.
Okay, thank you, and thank everybody for joining.